Okay, a lot of exciting events this morning, and as we can just see from this presentation for the Innovation Grant, only through knowledge will we have solutions. Okay, to close out activities for the morning, I'd like to invite our moderators for this session for poster presentations, Dr. Rachna Shroff, a dear friend and colleague. She is a professor of medicine at the University of Arizona and has many leadership roles there, including Associate Director of Clinical Investigations, Chief of the Division of Hematology and Oncology, and Associate Dean for Translational Sciences in the School of Medicine. She also serves on the Scientific and Medical Advisory Board for the Cholangiocarcinoma Foundation. Accompanying her is Dr. Ana Lleo. Dr. Lleo is at the Humanitas University in Italy. She has been instrumental in the European Network for the Study of Cholangiocarcinoma, what we call ENSCA, and she has been very instrumental, along with others, in many of the partnerships that CCF has had with ENSCA over the years and continue. So I will turn the floor over to Dr. Shroff and Dr. Lleo.
Thank you very much. It's really a pleasure being here in this session in which we will give the floor to poster presentations that have been selected for an oral discussion with you. So our first poster will be presented by Dr. Matt Cooley, liquid biopsy-based DNA methylation for the diagnosis of pancreatobiliary malignancies. Please.
Great. Thank you for the opportunity to share some of the work that our team at Mayo Clinic are doing, trying to validate liquid biopsy-based DNA markers for providing a better diagnostic test for pancreatobiliary malignancies. Let's see if I got that right. All right. So we have a couple minutes to go over my poster, so hopefully everyone can read that in the back. Try not to strain your eyes too much. But here's the poster to come and find over in the poster hall. I'll just quickly go through the background. Much of this has been covered. I think just one key component to highlight, our team was looking at a better diagnostic strategy for malignant pancreatobiliary strictures. So this primarily consists of the extrahepatic cholangiocarcinomas, and we're really focusing on that key component of early detection is vital, as that dictates treatment options for these patients. So some background on the early detection of cholangiocarcinoma. In terms of the gold standard for diagnosis of malignant biliary strictures, brush cytology is currently the gold standard. While diagnostic specificity is around 100%, which is excellent, the diagnostic sensitivity is somewhere around 20%, which leaves much to be desired. There's also some collection limitations with brush cytology. It's endoscopist dependent and really relies on the clinician brushing the appropriate site for a good diagnostic test. So our team wanted to look at methylated DNA markers and how we could implement those in kind of a clinical testing strategy to better diagnose these cancers. Just a little background on methylated DNA markers. They're currently used in colorectal cancer screening tests and just recently hepatocellular carcinoma screening tests as well. So our group over the last several years went through multiple different phases of discovery and technical validation cohorts to identify and refine an ideal methylated DNA marker panel to better diagnose these cancers. So I'll first, just for some background, share some brief results on our brushed studies. So in our brushed biliary brush sample studies, we identified a 4-marker methylated DNA marker panel which outperformed the current diagnostic testing strategies and improved that cytology sensitivity from somewhere around 20% to almost 75% sensitivity in our cohorts. And when we compare that to current diagnostic testing approaches, when we combine that with the other methodologies, we can improve the diagnostic sensitivity up to nearly 90% while maintaining still a strong specificity as well. So we want to take the same approach and the same methylated DNA marker panel and validate that in a liquid biopsy approach, looking at bile and blood samples that were collected at the time of the biliary brush sample collection. So just briefly with this workflow, we extracted the DNA from blood and bile samples, and then through a relatively new PCR approach called digital droplet PCR, we quantified the DNA hypermethylation at the specific genes of interest. In terms of patient demographics that we used for this last validation study, we had 160 patients with pancreatobiliary malignancies. 114 of those were cholangiocarcinoma patient samples. And we'll just kind of walk you through some of the results very quickly. We just compared the AUC values. So area under the receiver-operator curve is a result that tells you how good or how poor a diagnostic test performs. So 0.5 is about flip of a coin. 1.0 is a perfect test. So as you can see, our blood panel with the approach we took didn't perform that well, performing worse than another commonly available blood-based biomarker, CA19-9. But our bile-based methylated DNA marker panel did demonstrate a pretty well area under the curve of 0.84. So when we combine the bile MDM result with the CA19-9 value, that does improve the diagnostic area under the curve up to about 0.87, which is a good number to achieve with a diagnostic test. So again, just this bile MDM panel does display promise for potential diagnostic utility as a standalone assay, but more importantly, when combined with current methodologies that are out there. And I'd be happy to discuss this project and some of the other work we're doing with everyone at my poster, which I believe is right after this. But just in the last few seconds, none of us do our work or our research in a vacuum. I really want to thank the large team that supports the work that we're doing. So thank you.
Oh. Dr. Cooley, we wanted to see if anybody had questions for you. I apologize. We have time for probably, 1 or 2 questions for each of these, so we wanted to have give people the opportunity if there is a question related to this, and that's really wonderful work.
Oh, sorry for running off. I thought we were discussion at the posters, but yeah, happy to take any.
Just a very quick question here. What are the next steps needed to get this into the clinic?
Yeah, that's a great question. So our team in the clinical pathology group at Mayo Clinic, they're currently doing clinical validation for the brushed base approach. We still need to do some refinement. How would this workflow fit into clinical practice in terms of specimen collection and specimen routing? I think we need to play around with that workflow a little bit before we pursue the bile-based testing. And then, of course, with the blood results, I think we're really reevaluating how do we approach that. But part of this work is in that process, that pipeline for clinical implementation, which is exciting.
Just a brief question. Were these patients, I don't know if I missed it, like any of them PSC patients, or in that case, were the endoscopies protocol designed or
Yep.
Under clinical request?
Yeah, I have that on my slide and on the poster, but we do have a fair number of those patients who are PSC patients, and all of these samples were collected as part of their routine clinical workup. So again, that's why this was skewed towards extrahepatic cholangiocarcinoma. So these were patients that presented for advanced endoscopy as part of their either therapeutic or diagnostic workup.
Briefly, microphone 1.
Do you see a lot of variability between samples on methylation from the bile related to infection, things like that?
No, that's a great question. So we didn't actually consider infection in terms of this methylation profile. We identified methylated DNA markers that had a strong association with cholangiocarcinoma, but we didn't look at infection as one of the variables we analyzed. But great question, something we should look at.
All right, thank you so much. And we would now like to invite Hannah Stumpf, Dr. Hannah Stumpf, to the podium to present. Oh, sorry. I apologize.
Hi, everyone. Thank you for the introduction. If I would have known I only had 5 minutes, I would have made my title a lot shorter. So in brief, we're interested in looking at the subtypes of cholangiocarcinoma and their immunology. So cholangiocarcinoma, or CCA, is traditionally classified into the anatomic subtypes of intrahepatic, perihilar, and distal, with perihilar and distal often being grouped together as extrahepatic. But, and I think most of us know, the anatomic subtypes differ in more than simply their location along the biliary tree. For example, they differ in, oh, we went backwards. They differ in epidemiology, clinical presentation, and risk factors. However, there is a lack of information regarding the tumor immune microenvironment, or TIME. And this information is of utmost importance as we utilize immunotherapies like durvalumab and pembro in future immunotherapies. So this need leads us to our driving research question, which is, are the immune microenvironments of intrahepatic, perihilar, and distal CCA actually distinct? We sought to answer this question utilizing single-cell omics, and this includes single-cell RNA as well as protein sequencing. We collected specimens from 17 treatment-naive patients undergoing surgical resection for their cancer. These samples included the tumors themselves, as well as normal bile duct and liver. These samples were then dissociated into a single-cell suspension and flow sorted for CD45 positive cells. CD45 is a marker exclusively expressed on immune cells. We were then able to sequence this fraction using single-cell RNA sequencing, as well as site sequencing. And this is a technology allowing us to identify 160 proteins on the surface of each and every cell. Using this data, we're able to visualize the cells in a two-dimensional plot. And as of today, we have analyzed over 180,000 quality immune cells. Using the RNA and protein data, we're able to not only identify the type of immune cells, but also their abundance in our samples. So we found that in extrahepatic samples, the abundance of the immune cells varied greatly. I'm going to attempt to use this. In our B cells, we can see the great difference between the different samples as compared to intrahepatic. This is also notable in the CD8 T cells and myeloid cells. We also noted that intrahepatic shows a significant increase in CD4 T cells. In probing this further, we found 13 subpopulations of CD4 T cells, which express different markers of different functional states. One of these functional states has been described as stressed T cells. And just as stress can make you more ineffective at your job or giving a presentation, for example, stress can also affect the way or hinder T cells in attacking cancer. And so from our data here, we see that in intrahepatic cancers, these T cells are greatly increased as compared to extrahepatic. These cells are implicated in immunotherapy resistance, and we are currently probing and trying to understand the role these cells play in the context of CCA. So this is just one example out of many from our single-cell sequencing data set, which shows that the intrahepatic and extrahepatic cancers are indeed distinct in their tumor immune microenvironments, and that these distinctions may affect the way they respond to immunotherapy. So thank you for this honor to stand here today and present our work, and I hope to see you at my poster. Thank you.
So,
Questions, right?
no, we have just learned that there is not enough time for questions, so you can find her, the soon-to-be doctor, at her posters, and she will be willing and more relaxed to answer all the questions you have.
Thank you so much.
So our last poster will be presented by Younghun. I hope I have pronounced it right. And he will be presenting his work on genetic susceptibility to cholangiocarcinoma.
Thank you for inviting me to present genetic susceptibility of cholangiocarcinoma. Cholangiocarcinoma is a rare and aggressive cancer of bile duct with a poor prognosis and limited treatment options. A genome-wide association study compared the genome from many people to find the genetic variant associated with a particular disease or trait. A few GWAS were studied in cholangiocarcinomas. A few studies were examined the causal effect of CCA risk factor on the CCAs. We conducted 5 genome-wide association studies comparing 2366 cholangio patients and 12,000 persons without cholangiocarcinoma in European ancestry populations. And then we performed the univariable Mendelian randomization to examine the causal relationship between 36 CCA risk factor and CCA using MR method. This Manhattan plot shows 5 CCA GWAS result. Each point represents a genetic variant. X-axis shows the position on the chromosome. Y-axis means how much it is associated with cholangiocarcinoma. The solid line in red represent genome-wide significant p-values. The dotted line in blue indicate suggestive significant p-value. As you see, top and bottom panel, there are significant genome-wide significant in HLL region on chromosome 6 for overall CCA, intrahepatic CCA, and PSC-related CCA. Also, we identified 2 novel genome-wide significant signal in HLL region on the chromosome 6 for overall CCA. On the chromosome 4 and chromosome 7 from extra CCA and non-PSC related CCA. 14 new loci with blue-colored gene name showed suggestive signal. The interesting, one of the interesting gene is CLPT-M1L genes. Polymorphism in this gene have been reported to increase the susceptibility to several cancers, including lung, pancreatic, and breast cancers. This table shows the causal relationship between exposure and cholangiocarcinoma. P-value in red indicate significant P-value after bumperinol collections. P-value in blue indicate nominal significant in P-value. For Grimm's trait, genetic risk to fasting insulin was associated with increasing risk of intrahepatic CCA. For medical conditions, PSC was associated with increasing risk of overall CCA and PSC-related CCA. PSC was associated with increasing risk of overall CCA, extrahepatic CCA, and PSC-related CCA. Last one is associated with cholangiocarcinoma was associated with increasing risk of overall CCA and non-PSC-related CCA. Our GWAS reveals potential genetic risk associations. Also, we found strong evidence that fasting insulin, UC, PSC, and cholangiocarcinoma can affect the risk of developing cholangiocarcinoma. We appreciate all participants from all study sites worldwide. Thank you.
Thank you to all three presenters for outstanding highlights of their posters. And now we would like to encourage everybody to enjoy the poster walk. We really hope that you all will transition to that area and engage with all of our fantastic poster presenters. There's some really great science and data out there. Thank you.